Hello and welcome to the episode 3 of the season 3 of the Euro Health podcast. My name is Jiří Svoboda and our guest today is Dimitrios Athanasiou, President of Rare Diseases Greece and patient expert in the European Medicines Agency. Dimitrios, welcome.
Nice to meet you. Thank you for having me.
So our topic today are rare diseases and the policies related to their treatment, mainly on the European level. But I would like to start more on a personal note, because you got involved in this topic in the space when your son was diagnosed with Duchenne muscular dystrophy. This is a rare disease and incurable disease. Can you briefly explain what is this disease about to get a perspective on how these diseases affect people?
Thank you so much. Yes, it's as you said, Duchenne is a rare disease. So in my previous life, I was in finance, but 13 years ago, my son was diagnosed with Duchenne muscular dystrophy. And this is a rare disease, a neuromuscular disease that destroys our muscles. It starts with the legs, and then it affects the hands, cardiac muscle, and every other muscle we have in our body. Obviously, it's untreatable. Incurable at the moment, although there are a lot of clinical trials and a lot of research, but still we lose our children, let's say, by the late 20s or 30s. Mm-hmm. So yeah, it's a disease like most of the other rare diseases, let's say the pediatric onset.
Mm-hmm. Mm-hmm. So, of course, Duchenne muscular dystrophy is not the only disease of this kind. There are over 7,000 of rare diseases. Can you say a bit more about how are they different or similar? Because it seems like a huge number of diseases that need to be somehow treated.
Yes, I think they are also expanding, because with the new technologies and the new diagnostic tools, we can identify diseases that, let's say, we have to remember that 50% are pediatric, and even I think 30 or 35% of the children don't reach to the 5-year-old. And in the past, these were the diseases that were undiagnosed. These children were undiagnosed. And even now, the percentage of diagnosis is around 50%. So there is a difference, because you have 1 in 12 persons, so it's a huge number. It's 30 million people in Europe. And if you imagine that the half of them are undiagnosed, then you have extreme burden to the patients themselves, but also extreme burden to the healthcare systems. So let's say they are different, although if you take them one by one, there might be a small number. There might be 2 people in Europe. But if you take them over whole, they are 30 million. So you have to do something about it.
Yeah, they are not as rare as one might think. It's 36 million people in Europe, which is a population of entire countries, right? So I'm maybe interested in what was the first reaction of authorities and people in Greece who were probably in healthcare system who were concerned with the rare diseases at that time, 13 years ago. How did the reaction look like? What was the support system like in Greece?
Well, I think it's looked like mostly how the rest of Europe is. First of all, it depends what type of disease, let's say, you have. Our disease is genetic, so you have to, like this, I think 75% of the rare diseases. So you have to walk the path to get a diagnosis. For us, it was pretty easy, because it was a blood indicator that helped us identify the disease pretty fast. So, I mean, we went to the pediatric hospital with stomach pain or something like that. We did some basic exams, and then we left 2 weeks later with a rare disease. That was a short pathway. But we have to imagine that the pathway of rare diseases are usually between 8 to 30 years to get a diagnosis. If you reach there, then it depends what type of disease you have. So if you have a patient organization, if you have a unit that knows that type of diseases. On that part, we were lucky enough that we had a patient organization, and at the same time, Duchenne is one of the diseases that you cannot hide. It's not an invisible disease, because the kids are using wheelchairs. The diagnosis comes eventually. So the system was semi-ready, if we can say, the level of diagnosis. But there are other issues that you face. So like in most of the other countries, when you get a diagnosis like that, most of our clinicians, our healthcare professionals, don't know how to give you a diagnosis like that, that you have a terminal disease. So there are gaps, let's say, in the system that definitely need improvement.
Mm-hmm. But the diagnosis is only the start of the process, right? Like, what were the next steps? Was the system supportive enough in the following steps of the treatment?
As you said, the diagnosis is the first step. After you get the diagnosis, it depends if you have treatment or not. So if you have a treatment, you receive a treatment, let's say, for your rare disease. In general, in Greece, although with delays, we get a treatment, for example, that are needed for the patients with rare diseases so far. But after that, you have to have your center of excellence, your reference network. And although in Duchenne we had this, in other rare diseases they are not. And now we're trying to develop also with the Ministry of Health to develop these centers of reference and centers of expertise that the patient with rare diseases can go to one place that know their disease and get support and get help. That's the medical, let's say, part. And then obviously you have the social part that it depends in each country, it depends on the resources and the finances of each country, that it provides less or more resources to the patients. But this is for disability, let's say, and social protection that has to do with all diseases, not only rare.
Yeah, you mentioned the social support. I guess that the very treatment of the treatment of the very disease isn't the only part of support the families really need. So, what do we, as a patient's advocate, what do you hear from the families? What are the most important support they want?
I think you are super right, because 95% of the diseases don't have a treatment. So obviously the other items is what you need. And I'll give you an example from Duchenne. So the last 7 years after we published, let's say, the guidelines of standard of care, the children, and following the standard of care, the children improve life expectancy by 10 years. Which means that you don't only need, let's say, a medication.
Sorry, considering the fact that they actually would die in their 20s, early 20s, right?
Yeah, they were starting early 20s. They would try. It is significant, especially with no treatment. I mean, we only use some corticosteroids or something. So access to very good care, access to physiotherapy, hydrotherapy, and every other item, let's say, in the list is not given and it's not standard. And this is something that we all the community is working on, because it's completely different if you have, I don't know, you break a leg, or you have an accident and you have to rehabilitate, or you have a stroke. And it's completely different if you have a very young child that looks normal, to justify why this child needs physiotherapy or hydrotherapy, because you try to work preventively to maintain, let's say, its condition, its good status. So it is not let's say, a simple, straightforward line. And the other part, obviously, is the social protection, the social care, because the very big percentage of the families, because diseases are genetic and many are very, very difficult ones, you have single parents and you have single parent families, which increase the burden and also decrease the care that the child or the patient is receiving. So there are a lot of items, let's say, that need to be worked and need to work on, and the community is working on that.
Sorry, you said that the fact that there are single families with children who have the rare diseases decreases the quality of the care.
Yes.
How does that happen?
Well, it's very simple. If you have, for example, a child that requires, even to a financial level, if your child requires 500 euros per month or 1,000 euros per month care, and you have one income in the house, you are in trouble. Or at least you have less resources. If you add on that you might have a second child with the same disability, because these are genetic diseases, that increases the level of difficulty. And if you have to care for this child, so if you are a mother that you have a child with disability in your house, can you really go to work? That's a third level of difficulty. So obviously it affects a lot in, let's say, the financial part. It affects a lot the quality of life inside the house. It affects also the mentality of the house and the support that you receive as a family, let's say.
Yeah. I mean, it's a rare disease which doesn't get a lot of attention, so perhaps it must be frustrating for the families to become to be and to like try to survive and basically try to live still and progress in the treatment while there is a little public support, as opposed for like large scale and much larger diseases that like cancer or something like that, right? So this is a mental,
I think,
psychological burden as well, I guess.
I think it's a huge psychological burden, because you have to consider that most of them are genetic disease. So they are coming, let's say, from their mother, or they're coming from the father side, or the mix. That means that you give a terminal disease to your child, which is completely different if you get sick by cancer, which is also extremely serious. But as a carer or as a parent, you don't feel the same responsibility, because most of the mothers are feeling that they gave the disease to their children. Mm-hmm. And you understand that this is very complicated. And at the same time, you have social discrimination, because also same, because if you are a carrier of a gene, then might be maybe your sister or your aunt or your cousin is also a carrier, which means that you have to be very careful to what you say and to who you say to.
Yeah. So in terms of the inequalities in access to this to the rare disease treatment, we kind of already mentioned the single parents. You're saying the social disparities are by no question there. What are if we zoom out to the pan-European level, is it possible to distinguish what are the member states or possibly subgroups of people, subgroups of Europeans which are discriminated or don't get as equal treatment for rare diseases as perhaps in other countries?
This is a very general but also very tricky question. Well, I would say that we have to consider them in two levels. The one level is the normal discrimination that people living with disabilities have, comparing to the rest, that they don't have any obvious disability or any disability. So this remains, I think, beyond rare disease to all our people. The difference maybe is that disabilities in children, for example, because I was in the pediatric committee of AMA, disabilities in children are not usually because, let's say, of the football or an accident. Usually they are because of a rare disease, which also gives a very big challenge to the schools. Because, for example, in our schools were not ready to accept a child with a wheelchair or an electrical wheelchair that he cannot move out of his wheelchair. So many of the children are excluded from the schools. Many of the children are hidden inside their houses. Like I remind, the genetic factors. Many of the people, not only the children, are experiencing this inequality in that part of, even the movement, even to access to the normal, things that everybody else does. But if you move to the next level, then you have your rights. And what are the access you have in your rights? We have to consider that this is a very sensitive population. And as we said, very big part of it is experience poverty, is experience limited resources and social exclusion. That means they even have less access to their rights because they don't have enough time to look for them. They don't have even to take legal advice. So it's not an easy pathway, even if we keep it, let's say, to legislative disability side.
But if we look at like healthcare systems in different European countries, you said that the Greece system was semi-ready for the treatment of Duchenne. But what about other countries? Are there similar ready? Are there all similar ready, or are there big disparities between the quality of care?
In rare diseases, we call it a postcode lottery. So you live or die depending on which, let's say, postcode you have and which country you have. The truth is that we have very big differences. So if you are living, let's say, but like in every other thing, if you live in a country that it has more resources, then in theory, usually you have better access. And I will not say to treatment so far, to tell you the truth, not to medicines, because we don't have a lot of medicines. But even in the few ones that we have, yes, you have faster treatment, faster access to the medicine. So the one equality is definitely this. The second equality is access to care, to proper care. But this might not be only inequality inside, let's say, the different inside the countries between them, but also inside your country. So if you are living, for example, if you are close to Motul, or if you are close to the Greek centers for children, you might have a good care. If you are living to an island, or if you're living to a mountain, then you don't. That means that affects your life expectancy, or even cuts it by half. And in case of emergency, it cuts it at all. So obviously, there is a lack of, there is a very big difference. Yes, there are countries, as in everything else in, let's say in healthcare, that we have difficulties. We have difficulties in the Balkans. We have difficulties in some areas in Eastern Europe. We even have difficulties in the Nordics, which, let's say, we find surprising for rare diseases, but they are there, or Netherlands, or UK. The difficulties are an equal thing. We have difficulties in every country.
Mm-hmm. So over the years, you became one of the leading figures in advocacy for patients in rare diseases in Europe. You talk with quite a lot of legislators and lawmakers, both on national level in Greece and the European Union. When you approach them with the issue, perhaps, let's say I'm a lawmaker, I never heard about rare diseases before, or I do care about healthcare, but it's a rare disease is like so below my radar. It's not a significant issue for me as a lawmaker. How do you approach these guys? Like, how do you get them to care about the topic?
What is your elevator pitch, you ask?
Kind of, yes.
Yeah. So I think there are some items. It depends, first of all, the relationship that they have with the other, how you can say it, expertise in the field. So if it comes, from economics, for example, you can simply tell them that it's going to be the treatments of rare disease that are going to explode your healthcare system. So that gets their attention. Because fortunately or unfortunately, we have a lot of drugs coming, especially new technologies, because the technology in drug development is coming from rare diseases. All the ATMPs, the advanced technology medicines, medical treatments are coming from rare diseases, or at least 90% of them. Mm-hmm. And obviously later, they will become cheaper because these technologies will move, let's say, to the other more bigger populating affecting diseases, more chronic ones. So the one you try to explain is that if you do not have a plan to deal with the problem now, then you will not be able to deal with the problem at all. Mm. Because these treatments, although they are, let's say, for very few people, accumulative, they will have a high impact in the budget, in the health budget impact. So you need to have a plan. Mm-hmm. If you don't have a plan, you are a plan for disaster. So if it comes, let's say, from that part, it's pretty easy, because I come from finance also, it's pretty easy, let's say, to persuade. But if it comes from other modalities, then I would say that the rare diseases are affecting 1 in 12 people. So it's smart, because it's 12 people in our immediate family. Yeah. If it's not our children, it's the children of our children. It's smart to make some action and deal them now. Hmm. So in both level, national and international, global actually, we try first of all to develop treatments, to develop structures like the ERNs, the care centers, to promote research, but also to build, let's say, sustainable and tolerable healthcare systems that can tolerate this evolution.
Mm-hmm. Mm-hmm. And so that would be the economic side, which I would imagine persuade a lot of politicians. But what about the political side of it? Let's say, as a healthcare legislator, I only have like one brain and one work week, right? It's so I may rather choose like to focus on cancer or heart diseases or leading causes of that in Europe. How do you get past these issues to like elevate the importance of rare diseases?
Well, I think it depends what is the interest of the politician you have. So if it is the votes, then you have to get your voters together. It's like in every other thing. If you have to lobby, then you have to lobby together. Getting your advocacy right, getting your story right. This happens to all the advocacy and I would say policy, let's say, efforts. For us, for example, in Greece, we established the umbrella patient organization because before we were broken, we had too many small organizations, and that didn't work. It didn't push, let's say, the system forward. The moment we established rare disease Greece was the national umbrella, we managed to persuade to be part of the Ministry of Communications, to be part of the discussions, part of the committees, actually create the first draft of the national plan for rare diseases, which is mandatory and should be done by all the EU countries, and we are far behind. And then the next level is obviously the European plan for rare diseases. And I hear what you say for, let's say, death, mortality rates from various diseases. I can tell you that if you look, for example, in the pediatric, because pediatric cancers are rare diseases, are rare cancers. If you look at the mortality rate of the children, I saw a published research in Ireland for the last decade, and 67% of the beds in the hospitals that were taken by children, let's say, that would die, they were rare diseases. So yeah, I would say we have our part of mortality pretty high also.
Again, not as rare as we might think. So let's go to the exact legislation, and mainly on the European level. In general, you've been part of the talks with the European legislators for some years now. Do you see significant progress in the legislation and the efforts to pass legislation that would support rare disease treatment?
In general, by choice, I'm an optimistic person. So I would say, yes, there is progress. The question is, there is enough progress? Is there enough progress? And I will explain myself why. We had this orphan drug legislation, which was very good. And it worked. On the other hand, the last 20 years, we have developed, I think, 180 drugs for 7,000 rare diseases. So yeah, we need a couple of millennium to cure the incurable. So obviously we need to do something better. I think the technologies may be advancing more than our policymakers are advancing. So we are expecting, let's say, we're putting, let's say, more hope to the technology and the drug development pipelines than we put to our legislation. And the new legislation is a good legislation. It makes sense. But for us, at least for rare diseases, it's not brave enough. It didn't move, far enough. And we also have some concerns with the disappearance, for example, of the COMP, of the Committee for the Orphan Products. Also, in the new legislation, there is not going to be a PDCO, a pediatric committee in the EMA, and there are going to be working groups. We'll have to see how this works. This is my personal opinion. I can express only my personal opinion. I don't think that, I think we will lose a lot of expertise from these committees that we will need in the future, and the very close future. And I think the excuse was, or at least the justification, was that it will be faster in EMA to approve the drugs, I don't know, 100 days earlier than before. But the problem is that you need 2 or 3 or 4 years to get these drugs access to our countries. So, yeah, 100 days. Yeah, right.
Not great, not terrible. So overall, you just said that the legislation is not brave enough. Why is that? What are the points that are less ambitious that you perhaps want?
I think we need more ambitious targets. We need more ambitious and, let's say, mechanism and legislation that is flexible enough to accommodate this fast track developments in rare disease. Because the legislations, by the moment it will be written, it will be obsolete. The evolution is so fast in the field of rare diseases that, you need to have a flexible legislation. And we haven't seen how this will be incorporated, at least in the latest version. We are in discussions. I think people are understanding the concerns, but they are also, let's say, boxed in their own, let's say, framework. We need a mind shift. We need a new blueprint of how we can have development and access and participation of Europe in the trials even for rare diseases, because we see that we're losing trials to other continents. We are dropping behind in innovation. And this will cost us. This will cost us a lot.
Does that in the end discriminate European patients against, for instance, American or Chinese or other patients from other countries?
Well, it definitely discriminates. And I can tell you also, if we move, let's say, to legislation, to the regulatory part, that there are other also discriminations that that are very obvious and very worrying and very hard to justify. Because, for example, in Duchenne, that I know very well, we have in FDA in the US, I proved something like, I think, 7 products. And in Europe, we have 1, which means that we are missing also some kind of harmonization between the regulators. Because for us, even as a global, let's say, organization for Duchenne, World Duchenne Organization, it's very difficult to justify and to explain to our advocates why you have 7 products in one side of the ocean and 1 in the other. Something went wrong there, and I think we have to see what went wrong and how we have to fix this.
So you know what went wrong just yet in this regard?
I think we have an idea. We have an idea that the 2 regulators approve product differently. I would say that it is what it is, but I think the world is too small for rare diseases to do our job in silo. We have paid with lives in silo of data, and we will continue to pay in silo regulatory work also with our lives.
So you said that the technological advancements are often faster than the legislation. The legislation may be obsolete in the time it is approved. So how can the legislation actually support the technological advancements? Is it by less paperwork, shorter process of approval? What is the strategy there?
The strategy is not a simple one. And why I'm saying this? Because yes, shorter time of approval is a benefit. It's a good thing. We all agree on that. But we have to make sure that whatever is approved, let's say in the central level, for example in EMA, it has enough data and it has a mechanism to manage the risk, the uncertainty inside, that the other stakeholders down the pipeline, which means HTA agencies, reimbursement agencies, insurance companies, are willing to take this, let's say, uncertainty or know how to manage this uncertainty. Hopefully, with the joint HTA and the United and all of the efforts that are happening, hopefully this will be a better off. The second level is that we need to adjust our reimbursement systems, our evaluation of drug systems, because in Europe, for example, now we don't have really effective payment according to the result, right? Managed entry agreements. So if you work for Dimitrios, I'll pay you. If it doesn't work for a day, I don't pay you. Or I'm having a sharing risk. That means as long as you work, I will give you some money. If it doesn't work anymore, I will stop payment. This will manage the risk for the payers. But these decisions and this kind of data should be collected in the beginning, including patient-reported outcomes, how the patient feels with the drug, if it feels that it works. Because this is what you don't cure, let's say, blood exams, you cure humans. So this kind of information should pass also in the legislative discussion. So that's the one part. And I think the second part is we need to be more brave in the way and more advanced the way that we do business. We cannot do drug development and we cannot do clinical trials the same way we did them 30 years ago. It's impossible. You cannot do a trial, for example, randomized, which is fantastic as a concept and execution, double-blind randomized trial, which is the best evidence, let's say, supportive evidence. You cannot do it in a population that you have 3 people in the world. You can't.
Yeah.
We need synthetic data, we need synthetic twins, you need new models.
So in terms of the different pieces of effort, the European Commission repeatedly dedicated funds for Horizon Europe program, and the European Parliament also recently published a study requested by the Subcommittee on Public Health on tackling rare diseases. Are these type of actions, these type of efforts already creating some results? Do you see a good path of progress in there?
I think we are moving. We have to see this how it will be translated in the programs. And fantastic, let's say, interest of the parliament, how it might be translated also in the IHIs beyond the horizon. But we have to see the results. If you ask me if we do have enough, let's say, calls for rare diseases that are, I don't know, something like 7% of the population, no, we don't. We don't. And even we do have some research projects that are very important for us, like Erdera, that's going to start soon. It's not enough. It's not enough. We're talking about projects that, let's say, we co-finance by 300 million, 200 million, 300 million, 400 million, let's say, if we're very lucky. We have to understand that one pipeline for one product might cost 10 or 20 million or 30 million.
That's a lot.
It means we need, yeah. And I think that's an airplane cost or something like that. So for 30 million, 36 million in Europe, we can give a little more than an airplane.
So is it a finance program really? In the end, is it the fact that just the European Union doesn't dedicate enough funds for treatment of rare diseases?
No, I think we can. We are doing better, and we will do better. What we need most probably is a central process of even purchasing rare orphan drugs for all Europe centrally, like we did with COVID, because this will manage the inequalities, but also it will manage the pricing, and it will also reduce the uncertainty. The second is, yes, we need more research, but we need also better research, patient-centered research, evidence-based research, better quality research. And I think by involving patient organizations in that part of research, to keep indeed patient-centered research, you have a better chance to succeed. And we need flexibility in the brain, both in the European level, in the Commission. I think everybody wants to, everybody has good intentions, but then you have to act. And we are judged by our actions, not by our intentions. So better regulatory work, better policy work, better legislation work. And maybe what we need is the final to get the European plan for rare diseases. I think it's about time, 20, 40 years later, that we are asking for it.
So you mentioned the European Medicines Agency before, which you are part of course. You said that there is some, if I understood that correctly, like a decrease in staff members, and there's going to be a decrease of people focusing on rare diseases. Did I get that right?
Well, with the new legislation, the proposal is that we will not have the committees, and this will be downgraded, in my personal opinion, to working parties. We have to see how this works. I'm sure the intention is good, and it's for the benefit of all, but we're very stressed about the result because you're losing a lot of expertise, both in these committees, in all the committees, let's say, that disappear. Also, we lose patient experts and patient advocates that were part of these committees, and we know that due to the time, due to the load, they might be forgot to be invited, or if they're invited, they will not have the same value as a voting member that they have now in the committee. So that's a problem. That's a downgrade, at least in my book. And it's not, I will not say we are missing staff. We are missing in general resources. My feeling is that we're missing general resources for EMA because the workload is increased a lot. You have the pipeline for rare disease exploded. Before we had, 10 gene therapies or 80 MPs in the pipeline, and for the next 5 years we'll have 200. So you need to have expertise, you need to have people, you have to have resources, you need to have resources to involve patients inside these procedures, and enough time. I think, yes, EMA needs more resources, like many of our organizations, but also it needs better involvement of patients. They have done amazing job, but we need to continue to do it and do it even better.
So with the new European Parliament and Commission coming into power now, what are the main improvements you'd like to see in the area of rare disease treatment in the coming years? What are the priorities?
The priority is that we need a plan. The truth is that we need a plan. We need a plan forward, and we need a long-term plan and a flexible plan. So we need the national plans in the countries, because this is a national sport. How you deal with rare diseases at the end, at the level of the patient, it happens in the country. But also, you need a European plan for rare diseases that was promised by the previous parliament and the commissioner. So we need to see this happening, and we need this to be executed and to be executed properly and effectively and measurably. So these are let's say the two asks that we have: the national plans at the national level and the European plan.
So what is the percentage of the countries, member states, which have the national plan for tackling rare diseases ready and in place now?
Well, I would say the percentage is not big. We have a new movement trying to refresh, let's say, their national plans or to implement the national plans. But these were plans that were designed and implemented, most of them, the first versions 20 years ago. So they are obsolete. I think France is doing a very good work. Italy is doing a good work, but we still have a lot of work. And definitely in Greece also we need a lot of work.
Okay.
So not a big percentage, I'm afraid.
There is a lot to be done. Our guest today was Dimitrios Athanasiou, President of Rare Diseases Greece and patient expert in the European Medicines Agency. Dimitrios, thank you so much for your time.
Thank you very much for your time and for your effort and building awareness about our community.